Welcome to Modern Management of the Older Adult, brought to you by the Institute of Clinical Excellence.
Hello, MMO community. My name is Anushka Raja, and I'm a TA in the Older Adult Division of the Institute of Clinical Excellence. And today we're going to talk about maintenance therapy under Medicare guidelines. But first, we're going to talk about what's going on in our community. For live courses, we will be in Victor, New York, June 24th through 25th. And then our big one, MMA Summit, will be in Lexington, Kentucky, August 12th through the 13th, which is a big weekend for us as we'll be rolling out our updated live course content, as well as the whole MMOA team will be together creating an epic weekend for y'all. So we would love to have you join us. And then for online courses, our next cohort of Essential Foundations will start August 9th and Advanced Concepts will start October 12th. So today we're going to talk specifically about maintenance therapy under Medicare guidelines. But for all other things Medicare, Alan has a 4-part series on the PT on Ice podcast with the fourth episode coming out in a couple of weeks. So keep your eye out for that. Part 1 covered what is Medicare, how to conceptualize it, and what are the benefits to patients. Part 2 covered how it might look like to take Medicare as an insurance-based clinic or remaining a cash-based clinic and how you can interact with Medicare coverage for that. Really important one that had a lot of stuff I didn't know. And then part 3 is it worth it? Is it worth taking the time to do the documentation and everything that you have to do for Medicare? And then part 4, which is coming out in a couple of weeks, and that will cover what you need to put in a note, how much you need to document, what can trigger an audit, and other things like that. But like I said, today we're strictly going to talk about maintenance therapy, including what maintenance therapy covers, what conditions are covered, what setting is covered, and some clinical pearls for documentation of these cases. Since we seem to keep getting questions about documentation after live courses, we really do look at the feedback. So no matter if you're doing rehabilitative or maintenance therapy, we need to understand what medical necessity is. So in order to be medically necessary, it has to be safe and effective treatment. You have to have a duration and a frequency that are appropriate based on the standard practices for the diagnosis or treatment. You need to meet the medical needs of the patient, and it must require a therapist's skill. So we're still pretty arbitrary with that. You need to look at whether the cost of treatment is reasonable considering the patient's chances of reaching a desirable level of function or relief. And then whether treatment will mitigate the patient's risk of suffering and even worse outcome if the current condition is left untreated, which is like a big one that we're going to look at today. A couple of things that I keep hearing from patients, and I've heard about this even when I was in outpatient ortho seeing neuro or more complex patients, is 1, they were cut off from therapy because they met the cap, or 2, because they were cut off because they weren't showing functional improvement, but they had falls after they got cut off from therapy or were worsening. Some of that might be that they weren't compliant with their home exercise program, but some of that is that their home exercise program wasn't at the intensity that they need because it wasn't safe for them to perform those same things at home. So really important things for us to keep in mind as we go through this content. Okay, so first thing, let's debunk the hard cap. So in 2018, Medicare actually got rid of the hard cap. It was repealed and replaced with an annual threshold. So now once that threshold has been made, we're going to fix the KX modifier, which a lot of our documentation systems have that built in, if skilled physical therapy continues to be medically necessary. And I will put in documentation that's skilled in like everyday notes. Skilled physical therapy continues to be medically necessary for X, Y, and Z. So in every note, it's very clear to Medicare why it is important that this patient continues with PT. The other part of that is there's a long-standing myth that Medicare does not cover services to maintain or manage the patient's current condition when no functional improvement is demonstrated or possible. So we're reaching that functional plateau. But in 2013, there was a settlement between Jimmo and Sibilis, might be messing up that name, but that resulted in clarification of skilled therapy services that aid in maintaining a patient's current condition or to prevent slow decline, which are also medically necessary. So I'm going to repeat that because that's really important. So this settlement resulted in clarification. It didn't change anything, just clarified that skilled physical therapy services are allowed to aid to maintain a patient's current condition or to prevent or slow decline that are also medically necessary. All right. So now that we have that covered, 2 reasons why we're not discharging a patient because they're not reaching functional progress or because they have met the cap. So when we're looking at skilled maintenance therapy, it's going to include a couple of different things. It includes design and instruction of a maintenance program, as well as delivery of that program to patients. So as a PT or PTA, you're able to deliver that content to your patients. When the therapy procedures required to maintain the patient's current function or prevent further deterioration of people that are so complex that the skills of a qualified therapist are required to deliver treatment. So we're talking about our patients with multiple comorbidities, progressive diagnoses, or just things that they just don't have access to what they need to properly load themselves at home safely. So the patient's special medical complications require the skills of a qualified therapist to deliver those treatments, even if skills of a therapist are not ordinarily needed to perform such therapies. So patient A might have a similar treatment that they're able to do as an HEP, but patient B has such complexities that you're constantly needing to modify or guard or monitor vitals while they are doing these treatments. That is going to be medically necessary under maintenance. Then you're going to look at the need of skilled physical therapy maintenance is patient specific, is not condition or diagnosis specific. So yes, you've heard me talk about someone with progressive diagnoses, but that is not it. It can also include patients that have cancer in remission but are unable to complete their programs at home at a necessary level. You can look at someone that has like cervical myelopathy, where they might not be in a progressive state, but they are so far progressed that they are unable to continue walking at home without assistance, without that guard to safely execute that. And you know that they would further decline without your therapy services. You can establish a maintenance program without establishing rehab or restorative therapy as long as documentation justifies the need for skilled therapy to maintain function or prevent slow or deterioration. You're going to hear me keep saying those words because those are very useful words when you are documenting. So I might have a patient with a progressive diagnosis like chronic Parkinson's disease, and they're coming to me on initial eval, and I'm going to set them up for maintenance therapy because I know that they're going to need continued therapy due to their progressive nature of the disease. Again, those are words that I will use. Due to the patient's to the diagnosis progressive nature, it will continue to need skilled physical therapy due to XYZ. And then, so skilled maintenance must still meet medical necessity requirements. You've heard me say this all along, but the services need to be reasonable and necessary and require skill of physical therapist or a PTA. Establishing a maintenance plan is covered under that. Instructing and training patients or caregivers on implementation of that program is also covered by that. Periodically assessing its effectiveness or need for modification meets medical necessity requirements as well. So all things to look at when you're trying to decide if this patient should or should not be under maintenance therapy. PTs and PTAs are both permitted to provide maintenance therapy under Medicare Part A in home health and skilled nursing. And then for Part B settings, we're going to look at outpatient, in the home, assisted, and independent living facilities, as well as SNFs. The coverage standards do not apply for inpatient rehab facilities or outpatient rehab or comprehensive outpatient rehab facilities. So just looking at that terminology will be important. There are the differences for that. But again, PTs and PTAs are able to establish that. PTAs need to work under the supervision of the PT, so the PT has created that program, but now the PTA can carry out that maintenance program. So just different things to look at. The bigger thing that I'm going to talk about here is verbiage, so I will repeat a lot of the stuff that I've told you already, just for clarification, because I know it's just hard to find the words sometimes to express why it's so necessary. So when I'm looking at a progress note or a re-eval for someone who is on maintenance therapy, I will write, skilled physical therapy continues to be medically necessary at a frequency of like 1 time a week, 2 times a week, for however many weeks, to help reduce falls, to maintain strength, to maintain current level, functional level, XYZ, whatever it is that they are needing to be there for. If I am looking at someone with a progressive diagnosis, I will write, due to progressive nature of patient's diagnosis, skilled physical therapy continues to be medically necessary at a frequency of XYZ for XYZ. Okay? So those words are very helpful in establishing whether or not we need that patient to be there due to whatever it is. You make it very clear to Medicare, no questions. They're not worrying about getting audited and then having to go through that process, as well as all the documentation changes that you might need if you go through that process. All right, so the other part, if it's another thing to look at is the complexity of comorbidities, right? So due to complexity of patient's comorbidities and diagnoses, patient requires constant monitoring. Thus, skilled physical therapy continues to be medically necessary for maintenance of this and so forth. Okay. When I'm writing my goals for these progress notes and evals, I'm going to look at a lot of functional outcome measures. So I'm looking at things like the 6-minute walk test, the Berg or the mini BAS, and I'm going to look at the gender and age matched norms, as well as consider the MDCs for their diagnoses. Sometimes you're not going to find that, but just even getting that gender and age matched norm will be helpful to you. You might not be meeting that standard, right? So for someone like a male and in his 70s, it's like 1,729 feet for a 6-minute walk test. Your patient might not be hitting that. So instead of saying patient will meet this standard, I'm going to set a maintenance goal around what they walked for their progress note or eval. And then I will say patient will maintain at least blah, 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 1,600 feet on the 6-minute walk test to improve ability to perform household and community ambulation. I will also put in when I'm documenting in that paragraph about what they had difficulty with while they're walking, why it's medically necessary. I will write patient required contact guard assist or min-A for stabilizing as we're walking. Patient demonstrated difficulty with turning requiring cues for stepping to decrease fall risk. Just different ideas. I know there's a lot of words, so always ask for clarification if you have any questions. But there's a lot of different things that you might see with your patient, and you just want to make sure you're documenting that in the eval or progress note or during your visit so that Medicare, again, has no reason to deny those claims because you made it very clear that a patient needs you with them in order to do those exercises. So again, I will put in every daily note at the end of my daily note that skilled physical therapy continues to be medically necessary for XYZ in order to maintain whatever it is that we're trying to maintain for that patient. Typically, it's like aerobic capacity, endurance, muscular strength, decreased fall risk, maintain current level of independence. So different things that you're looking at that. One thing to really note is for a progress note, which has to be every 10 days or 30 visits, and then for every plan of care, which has to be every 90 days, I can make sure my progress notes are signed as well by the referring provider, but at the very least, your plan of care update should always be signed by your referring provider, because that is where Medicare can say, okay, the medical doctor also thinks that this is medically necessary and in agreement with what the physical therapist is thinking. So not that we should have to justify that, we should have that autonomy, especially since Medicare lets us write that, but having that on file just is extra justification for what we are already saying is necessary. So one thing I always tell my students is that we need to show why we matter for patient care, whether it is a daily note, whether it is a progress note, whether it's eval. So if we are modifying activities for this patient, we are going to write patient's activity, like walking was modified to improve success with stepping over obstacles. You can say like, you decrease the height of that so that they were able to do that. And then you're going to progress that in further sessions as able. But definitely putting in what type of contact guard assist, what type of assist you're doing. Do they need min assist for stabilizing? Do they need mod assist for stabilizing? Do they need mod assist or min assist or verbal cues or visual cues for transfers? Definitely write in those things in your documentation. It takes a little bit longer, but it helps you just justify everything so much better. And then another thing is like, obviously we say vitals are vitals. So you at least want to have vitals for beginning and the end of every session for these patients that are, especially with cardiorespiratory issues that are Medicare patients. But especially if we have to do that throughout the session, make sure you're documenting all of that, because that is a reason we have to monitor their response to activities, and that's why it's medically necessary for them to be with us. So documentation is a huge thing. I get it. It gets really complex. There's a lot of words that we don't want to write because of time, but certain words are just necessary. Definitely just tell them why it's medically necessary. Tell them why your value is a reason, causing reason for this cost. Okay. So again, a few things to remember. Skilled maintenance may include design of and instruction in a maintenance program, as well as delivery of that program, whether it be just to the patient, whether it be instructing the caregiver as well. The need for skilled maintenance is patient specific, not condition or diagnosis specific. So as long as you're covering a reasonable frequency and duration for that patient based on their condition, you're fine with skilled maintenance. It must meet medical necessity. I can't push that enough. Must meet medical necessity. And then depending on your setting and the guidelines of your state, you want to make sure you're compliant to like PT, PTA supervision and within the different settings. All right. I know this was not the sexy topic. It's just one of those necessary topics. If there are any questions, feel free to reach out to me, whether it be via messaging on here. You can message me, you can email me, you can post it on the MMOA community Facebook page. We will always dive in and reach out back to you if you have any of those questions. Other than that, have a lovely night and thank you for joining me. Bye.
Thank you for listening to the MMOA podcast. If you found this helpful, please share with someone that could benefit. And if you're looking for more practical content to help you better serve older adults, head over to www.mmoa.online, where you can learn more about our free resources, our community, continuing education courses, and our certification. Once again, that's www.mmoa.online. Thanks for listening.